We have two speakers here for you today to talk a little bit about post-acute care and BPCI, the bundled payment program. And so I'm going to let them introduce themselves. It'll help a little bit with our speakers and those online, so we can say hello to everybody who's online today. And so we have Lisa Hines and Cassie McAllister, and they are going to have a great program for you so you can learn more about post-acute care and bundled payments. So I'm going to let them introduce themselves.
Thank you.
So Lisa, you want to start out?
I'll start out. So thanks, Jennifer. My name is Lisa Hines. I am the Vice President of Age-Right Care Management Solutions, which is a division of Marquee Companies, which Marquee Companies has 19 post-acute care settings in Oregon, California, and Nevada. I manage kind of the unique part of Marquee's business model, which is what we refer to as Age-Right, which we have a ISNP plan. Who in the room knows what an ISNP plan is? It's called an Institutional Special Needs Plan. So as we've been talking today about, you know, what happens with Medicare Advantage, it is a Medicare Advantage plan, but in order for them to enroll in our plan, they have to reside in one of our facilities and they have to have been there for 90 days. So it's kind of fun because I not only get to manage a health plan, Medicare Advantage plan, but I also get to manage a medical group that provides the care in our post-acute care settings. And then I also do the negotiations for a post-acute care network. So I have a lot of really fun things. My background is I've been in this chapter of HFMA since I think about 1989, maybe 1990. I grew up working at a health plan. So I started at Regents Blue Cross Blue Shield, which actually was Capital Healthcare, a small little HMO in Salem. And I finished my health plan career at Centene, the Oregon market. So I have Medicaid, Medicare background. So I'm super happy to be here today because I know lots of people here, but hopefully we can kind of help you understand how we can help you if you're in a bundled payment arrangement. Okay.
So she's wearing the microphone I have to talk into.
We're just
awkwardly
like
close. My name is Cassie McAllister. I'm actually a skilled nursing home administrator. I've been working for Marquee for 16 years. It's kind of funny to say that it's only my second job from college, but it's been actually 16 years. Like I said, we have 19, or like Lisa said, we have 19 skilled nursing facilities. We have the fifth, another arm of our company is Consanas Rehab and Pharmaceutical Services. We're currently the fifth largest long-term care pharmacy in the nation. We have rehabilitation contracts, speech, PT, OT across the United States. And so a lot of times if you are using multiple skilled nursing providers, it's likely that we'll provide either the PT or pharmaceutical services for multiple providers within a system. And so, like I said, I think we're excited to talk about BPCI. We had anticipated potentially having someone here that was a convener in Model 2. But she was unable to be here today, so we're going to give her story in a little snapshot. But we're really hoping to share what bundled payment looks like in advance, the Model 1, Model 2, and how preferred providers and potentially a post-acute care network can better your results and outcomes.
Okay. So today, really, we want to kind of background and frame from our view how bundled payments and how we work with acute care settings. We're going to provide you some insight into post-acute care. Like I said, I spent the majority of my career on a payer side, specifically on payer contracting. And before I got the amazing opportunity to come to Marquee Companies, I had no idea how much went into post-acute care. So hopefully I can enlighten you guys too and teach you something you didn't know. And then we're going to talk about data and how we can collaborate with data because we've spent a lot of time working through that process. We're going to do the BPCI overview, and then we're going to talk about the case study that Cassie just kind of referred to. So today, you know, at the end of the day, we have lots of conflicting processes within our business models. The acute care setting wants to get patients out of the hospital because the DRG reimbursement and those kinds of things. We want to bring them into our facilities, but guess what? If we bring them in too soon and they go back to your facility, we both get dinged. If we bring them in too late, we get a longer stay, we both get dinged. So really we have lots of common processes, but right now the way that accountable care and value-based and really in Oregon, the Medicare Advantage penetration is really kind of tripping us up. And I think between post-acute and acute, we really struggle to align ourselves and bring value to each other. So hopefully we can kind of show you how, if you can align with a post-acute care network or a post-acute care provider, that you align your goals, I think that you're gonna see some changes in BPCI or value-based contracts that you may or may not engage in from Medicare Advantage payers. So this is how we think about post-acute care, and you guys have gone through DRG reimbursement changes. We talked a little bit about capitation. We talk about all these things, but come October 1 of this year is the second largest change to post-acute care reimbursement since 1998. So we've been working on what they call a RUGS model, which, you know, I mean, in all transparency, it was how many rehab minutes can you give? And how many rehab minutes, I mean, that's what it was. It was like, do you give 70 minutes? And you can't give group and concurrent. Well, you can, but it has to be just a little bit. It was crazy how we all put it together. So while we believe we deliver a lot of really great care, the funding just wasn't aligned. So you go through this stuff, and now with PDPM, we're tipping ourselves upside down. I don't know how many, if there's any payers in the room, but I know when I was on the payer side, it was so frustrating to me because I would try to model a post-acute care network contract, and I could never get the units to line up. I could never get the diagnoses to line up. I couldn't get anything to line up. Well, it's because it wasn't important. Diagnosis coding in post-acute care prior to 10/1 of 19 didn't matter. So they just took whatever the discharge records had, and if the discharge records didn't get there in time, we took it, but we didn't validate it. We didn't do anything with it, which I think from the acute care setting and from the professional setting, that's very different, but it just wasn't important. It didn't drive reimbursement, so we didn't focus. So based on those kinds of things and what CMS has seen and what the Medicare Advantage penetration, I think CMS just came out and said, look, let's look at this differently, because rehab isn't the only reason someone goes to a post-acute care setting, right? We have strokes rehab, but I mean, there's just lots of different things. So then they bring bundled payments, one and, you know, the first side, and it was like, how many of you guys had BPCI the first go round? Anybody? OHSU did? Yeah. There's not a lot. We spend a lot of time with hospitals talking about BPCI, and I think going into 2020, I know Legacy is in, OHSU is in, who else, Cass?
Slocum, or just
Yeah.
hospital, Slocum, Hope, Legacy, all of the Legacy hospitals are in.
Yeah, so for those facilities, we really think from a network side, from a post-acute care side, we've got to work differently with them, because come 10/1/20 or 10/1/19, that diagnosis is going to be critical. And now the way kind of PDPM reimbursement is going, it's the first 3 days. So there's a ton of myths out there around PDPM and what's going to happen. But I think from our perspective, we're really worried about the little guys out there. You know, we've got 19 facilities, and our network partners, they have about, I don't know, 25 or 30 facilities. And we've been spending a lot of time on PDPM. We probably will hire a coder. I mean, how weird is that, that a skilled nursing facility is going to hire a coder? But those first 3 days are weighted so much heavier in the post-acute care stay now going forward, that if we don't, we could find ourselves in a lot of challenging situations. So when BPCI came in, we found ourselves from a data side, working with different partners. We had to help them because in the beginning, BPCI, I think providers thought that it was all about length of stay. So get them out of the hospital on that DRG, get them to a skilled nursing facility. They can't take too long because, you know, the national average is 23 days. And if you're anywhere close to that, you're a bad provider, and that's going to cost a lot of money. Well, that's not really what it is. I mean, really what it is the whole. So it's the initial hospitalization, the acute care setting, it's the post-acute care, whether it is in a facility or it's in the home health, wherever it is, it's managing that whole. So when we talk about social determinants of health, I'll show you some of the things that from the post-acute care side that we look at the whole setting. So essentially, we know there's risk out there, right? There's lots of different funding mechanisms. There's lots of different ways that we can work with Medicare Advantage payers, just as you guys have tried to work with them and do things different. Hold yourselves accountable, share in incentives, get paid for the quality that you're delivering. or the length of stay that you're delivering. But the problem is they're not ready. I think from our perspective, we've talked to every major payer in the Portland metropolitan area and really who's delivering care in Oregon, and nobody's ready for post-acute care to say, hey, we'll do it episode 2. You want to do bundled payments? Come talk to us. We'll do it. Because we think that we have the infrastructure that is there, and that we have the relationships with the acute care systems to be able to manage the whole of that patient. So we'll see, but you know, bundled payments is almost there, and some of you are in that, and it's all in. So you got to really think about all the pieces that go along with it. So what drives success from BPCI? You got to find the care opportunity. You can't just assume that it's length of stay. It's got to be, where is the opportunity to be able to manage that whole episode? And you got to have all of your people. We spend a lot of time working with your case managers and with, you know, your medical management teams. But I think if you're not talking to them from the finance side, I think you might be missing it, because there's a lot of opportunities there. You got to think about who are the providers in that bundle. You know, who is it? Do you just want all of your care managers to any post-acute care setting that works? Do you just want them to go to home health? How do you measure what's important there, and who is the provider that you're going to choose? Because that's going to be really important to you guys as you walk through it. When I say network, I mean who is your network of providers? It doesn't just mean that it's the clinical side. Who's going to do your transportation for you? Who's going to make sure that your home is safe for that patient when they leave, wherever they're leaving, whether it's your facility, whether it's my facility, whether it's my home health agency? Who makes sure that they're safe? You got to think about the whole of the network, because it will change the economics pretty dramatically. And then how do you determine the financial decisions? Cassie's going to spend a lot of time with you today kind of talking through BPCI and what we've learned from our Avamere partners when they went through the first model. And I think you guys will see the financial decisions are not just that $10 bill that Jeff showed this morning, you know, and it's not just the policy. It's got to be part of the patient too. So you got to think about that. And you got to have the analytics. And we'll show you a little bit about what we use today and how we work through some of those analytics together, you know, with our clinical teams and also with our financial teams. So who's in it? It's everyone. You know, it's you guys, it's the physicians, it's us, and ultimately it's the patients and how much they align with us. So what we've done, because we have a lot of clients out there that are in BPCI, we felt like we needed to bring to those clients a network that is stable and actually does the things that we think are important to us. So we created Age Right PACnet. And what it is it's a network of post-acute care providers. It's skilled nursing facilities, it's home health care agencies, and it's medical groups that provide care to the post-acute care setting. We have pretty high performing standards. We measure each one of our facilities on a monthly basis, and we give them a scorecard. And if they fall below 60% of our scorecard, which I'll share with you guys today, they don't get to be in the network. They have to be removed from the network, and they don't get the reimbursement from the Medicare Advantage plans that we've negotiated to be able to provide the care that we think is the quality care that our patients deserve. We measure member satisfaction on every single one of our patients that leave any of our settings. We think it's important to you guys, it's important to our Medicare Advantage payer partners, and we have to make sure that we have something quantifiable to be able to do that. And part of this all goes back to efficiencies. I think you guys would agree that times payer partners become a little bit redundant in the services that we provide. You guys provide great care, you provide management, we provide transitions of care, we provide great care, and all in all, you end up with authorization denials, technical denials for timely. You get all of these weird denials that really don't impact the patient care. So we've said to payer partners that with the 36 facilities and 13 home health agencies and our medical group, you get one set of standards. You get timely filing that's all going to be the same. You get an operational gold card from authorizations, and we'll hold ourselves accountable. If we keep someone longer than we should, we're going to take the hit for it, and financially we'll do it. So I think making sure that whoever you guys use in your bundles or as you transition people to post-acute care, make sure that your team is comfortable with the network, what you're getting. So here's our scorecard. Hopefully you guys can see it. We've published it. But essentially for us, and what you'll see, and I think you guys have the same thing, is that CMS measures us on these lovely scores that are, 18 months old. It's like it's nothing we can change today. It's nothing we can do with it, but it's out there and it's public, right? And so it's public. We have to be able to be accountable. So we measure that. So every one of our facilities, we throw our CMS scores out there and we say, okay, where you at? We also measure live readmission rates and ED and average length of stay. We know average length of stay is important to everyone because, if it's a per diem, it costs money, right? But all of these measures together create value for our acute care partners, because what happens if you guys get a high readmission rate? CMS dings you, right? Don't they ding you financially? Yeah, they ding us too. So, we have some pretty significant alignments economically. We are hooked up to, everybody know who CMT is? The EDDI report, do you know what EDDI is? So essentially what it is it's collective medical technology. It's a software that all of our hospitals in the state of Oregon have connected to that actually tracks every stay throughout our systems. So if someone is at Legacy Emmanuel and winds up at San Yam on the same day, you'll get an alert. Legacy will get an alert, San Yam will know, because it's all tied into the Epic system and they can tell. We were the first post-acute care providers to hook up into CMT. So we have live data. And literally, if somebody leaves our Tualatin facility and ends up back at Emmanuel, my Tualatin facility gets an email alert that says, hey, Mary Beth is at Emmanuel, what happened? And they can then reach out to the case managers and talk to them and say, hey, don't admit her, bring her back. We can keep her. Let's make sure that we're working together. So it's really, really innovative and it's important, and we take it really seriously because obviously the acute care side is pretty important to be able to understand that economic, and we get it. Then you get into, I'm sorry.
Can you clarify that everybody, all students have access to that EDDI system?
Uh-huh.
Can you repeat that?
Oh, sorry. So the question was, do all hospital systems have access to the EDDI system? And in the state of Oregon, yes, they do. Now, Emergency Department Information Exchange is what EDDI stands for. Okay. So the other thing we were just talking about during lunch hour was, the buildings and the private rooms. I get payers that tell me, Lisa, we don't pay for pretty, sorry. It's like, okay, well, you don't have to pay for pretty, but if you were sending your mom to a building that was, in excess of 30 years and hadn't had a remodel, maybe it's okay for you. But from us and what we find from our customer satisfaction surveys, it's not. People, that's not their first shot. And so we measure ourselves against that. It doesn't mean that you have to go do a, billion-dollar remodel on a 50-bed facility. It just means that it has to be updated and that we think that that's important from our patient perspective. So we hold ourselves accountable, and you should hold any of your network partners accountable as well. So this is the part of Lisa's lesson in post-acute care was I had no idea. So we work with the hospitals, with you guys, right? You guys want to discharge, they're stable, we're working together, we get the discharge records, all that stuff. We have hospital liaisons that talk to your case managers every day. And they're working to help the families and everyone get into facilities. And this is for our entire network. So if we discharge from Emmanuel, I know that Megan is going to have that conversation with that case manager, and she's going to place that patient at the right facility for the right level of care. We provide the transportation. I didn't know that a skilled nursing facility had transportation, but we take them to our facilities for the family. Then they get to us, And when they get to us, we all hire NPs and PAs, and actually we have some MDs and DOs that are our own medical directors. So through our analytics, we know that the best opportunity for reducing readmissions is to see that family within 24 hours of the admission. And the reason is because they get sad and they get scared and they're worried that their medications aren't right. And if they see a physician, it changes. We've seen some of our readmission rates drop 11%. Just because we had a physician there that could talk to your mom or your dad, you know? So I didn't know that. Physical occupational therapy, Cassie kind of talked a little bit about that. We hire our own physical and occupational therapists, and we actually provide them for many of the facilities in the state of Oregon, Maryville, Marion Estates, just all over the city. So it's kind of interesting. We have our own pharmacy services. We do our own medication reconciliation. So Paul kind of alluded to this morning about PDPM and how that's going to change for us going forward. Part of that is that medication reconciliation. We have to know that it's the right thing. So the discharge planning, the discharge records, all of those things are going to be even more important to all of us going into, and especially in bundled payments. Yes, Jennifer.
Can you explain what PDPM is?
PDPM is the next CMS methodology for reimbursing post-acute care facilities after 10/1/19. So the acronym is Patient-Driven Payment Method. And right on the heels on 1/1/20, you're going to hear PDGM, which is Patient-Driven Group Methodology, which is how home health will change as well. So CMS is really tipping ourselves upside down, let alone then we have bundled payments that we got to work together to try to succeed as well. So medication reconciliation, drugs to home, we discharge with drugs so that they can get home safely and they don't have to run off. We call the PCPs, we do the handoff, we do the discharge planning. We do home safety evaluations. So if there's a fear whether or not that person, so again, if you think about BPCI, right? You've got a DRG, you've got a certain number and you can't have readmissions and you got to hit that dollar. Well, if that person is going to their home and isn't safe, the home isn't safe, maybe we don't discharge them. We work together differently. That's where a length of stay might get longer, right? But it's safer than a readmission, I think. So things like that we're going to talk about. And then home health care. Because our home health care agencies are owned by ourselves, then they're all clinically aligned. They all share the same EMR. Everyone knows what's going on. And then, of course, we have 24/7, just like you guys do. So we think that a successful BPCI partner, network partner, really is all about the clinical integration. It's how we work together. So us having access to Epic and you having access to our EMR, which is PCC, is critical to make sure that we are all aligned in making this work. The key for us right now, though, is the payers. I don't know any payer that's doing any BPCI. We have to do this for CMS, but I don't know any payers in our area that are ready for that. So we're doing all this infrastructure with each other to get this done, but payers aren't ready to reimburse that way. So we got to figure out, how do we bring the payers along together to make sure that we're there? So this is how we do this. You know, we contract with payers. We make sure that we have sustainable providers within that can help the acute care setting. We make sure that the funds are, you know, sustainable. This is our network. So really what we bring to the acute care setting is a network of providers who understand BPCI is and align ourselves to be able to do it. And we pretty much can cover the majority of the state of Oregon, let alone other areas. So what I would say to you, you know, for those of you in other parts of the state, find the network provider in the post-acute care setting if you're thinking about BPCI that will help you and can align themselves and understands what's important. So Paul alluded a little bit to this morning about how many Medicare Advantage lives are in Oregon. Well, there's 36 counties in Oregon. All 36 counties have Medicare Advantage plans. Oregon is the second largest Medicare Advantage penetration in the United States. So for us, you know, I think we have to be much more focused around Medicare Advantage than other providers in the nation. I was in Chicago a month ago, And they have like 36,000 lives in the whole state in Medicare Advantage plans. So I'm talking to them about Medicare Advantage and how you work with payers differently. And they're going, huh? I was like, wait. And they just don't. But for us, all of our counties have Medicare Advantage payers. There's 389,000 Medicare Advantage enrolled lives in the state of Oregon. That seems like a lot, right? I mean, would have you guessed that? Who do you think the largest payer is statewide? Kaiser? You knew that, didn't you? Yeah, Kaiser's right up there. Providence and then United, I think, is how it structures. Different in different counties, you know, I mean, every county has a little bit different in the methodology, but it's there. So in our network, we have 36 facilities in 12 of the 36 counties. We have 7 home health agencies in 13 of the counties, and we actually represent 335,000 of that 389,000 lives in the state of Oregon. So because Medicare is the majority of our business, we do some commercial, but post-acute care really doesn't have the opportunity that the acute care setting has. And, you know, I know everybody loves the words cost shift, but the reality is we don't get, I mean, we get maybe 1 to 2% of our admissions are commercial. So we have to rely on Medicare and Medicare Advantage. And I bet you guys would have no idea. I would never take less than Medicare in your facilities. And there are many facilities in the state of Oregon on the post-acute care side that payers are reimbursing them with Medicare. So it's a challenge, you know, the money's not necessarily there, and we all have to work together to make sure that we're delivering the best quality of care that we can, but also being very good stewards of that dollar, because that's the way it is. So Cassie's going to step up now and kind of talk a little bit more in detail about BPCI. Anybody have any questions before I kind of step out of network and what post-acute care is? Yeah. Go ahead, Ken. Oh, microphone, okay.
You get to repeat the question.
Okay, repeat the question.
So how do skilled nursing facilities determine how much time will be devoted to therapy for patients?
So the question is how do skilled nursing facilities determine how much time will be devoted to patients? It's very clinical. I'm not clinical in any way, shape, or form, Ken. In the past, it really was based on the clinical protocols around the diagnosis that they were there for, or the DRG. The challenge that we had in the past prior to PDPM was because reimbursement was based on minutes, if you will. So I would say there were times where if it was, maybe we could get by with 60 or 700 minutes a week, but if you went 710, it went to the next rug, we probably would do 710. Now, all of that being said, it sounds kind of weird, but at the end of the day, all of it is measured from the success and the outcomes of those patients. So whether or not we want to believe it or not, that 713 minutes really does statistically walk out to better ambulation when they get home, better success in the home, all of those kinds of things. So, you know, my rehab team would probably be kicking me right now for me saying that, but it is, it's very statistically sound. So going forward, though, I would just say the change will be Medicare is now saying that we can do a lot more group and concurrent therapy. So on the commercial side, we could do group and concurrent, which basically means if I'm a therapist and I'm in the gym and I have someone on a bike doing bicycle work and someone else comes in at the end of that 15 minutes, then I could have that other person on a bike at the same time and I could bill for each one of those separately. So in theory, there's really only 15 minutes of care being delivered from my time, but it's 30 minutes because it's additional patients. So going into PDPM, CMS is saying that 25% of our therapy minutes can be group and concurrent, which in the past, they wouldn't let us do any group and concurrent. So that's why PDPM and rehab will change a lot in the methodology going forward. Does that help? Probably more than you wanted. Sure. Yep.
So the fear that we have, or our therapy that our operations people have, is that with PDPM, there might be reduction in therapy because before you were awarded high drug for therapy nowadays. So is that a valid fear? They feel that the group and concurrent doesn't work as well as individual therapy. So there's two fears that you have a response to that.
So the question is with PDPM, there's a fear in the community and a myth really that we will reduce therapy minutes to save money because we won't get reimbursed for it that way. Does that restate pretty good? And honestly, we have looked at this inside and out, and we don't think so, because when our clinicians look at our patients, they really do know when group and concurrent is reasonable and when it's not. And so we believe that doing group and concurrent in some instances is actually better for the patient, because if you're doing, if a patient is motivated or is competitive, right, then you have that opportunity to put them on a bike together, and there's some competition there, and we've seen better success that way. We honestly don't know. I mean, what we're worried about more so is for those facilities that do think that way, and not so much that they're going to reduce therapy, but they're just not going to take your patients. So there's a risk in PDPM where if a patient is super or not very high acuity and is mostly rehab, you may have a hard time placing them because of those kinds of myths. We're not really going to, do you see why I would say that? Because PDPM is loaded. It's loaded reimbursement wise to the first 3 days of the stay. And let me maybe put this in context so that now I'm my Medicare Advantage person. So my Medicare Advantage plan, all of my members live in our facilities. So they probably have some pretty high disease state, right? Lots of chronic conditions. All of my physicians are trained on palliative care. We do the whole gamut. My fear with PDPM is I have a really high acuity on my patients, right? And on my members. They're going to go to our facilities, and because PDPM is loaded so high on the first 3 days, what do you think someone who is in a long-term care setting needs when they go to a skilled nursing facility? Super high acuity. So I'm more worried that I'm going to wind up paying more in PDPM because of the sickness of my patients. Does that make sense? So there's a lot of things. You know, the thing that I would say too, going into PDPM and really just kind of going into BPCI as a whole, is we have some opportunities to really think about the care that we're delivering at the right setting at the right time, right? Does it make sense to have a 87-year-old who is in a institutional setting, and I mean like a ICF setting, not assisted living, but in an ICS setting that really can't live on their own, still on statins? I don't know. I mean, I don't know that I want to be on statins when I'm 89 years old and I can't, you know, take care of myself. Why would I do that? So I think that we as a healthcare continuum, we really need to start thinking about that.
Have you done a pros and cons of PDPMs? Do you have a slide or?
We don't have a slide, but we actually can show you. We have a tool that Cassie's going to spend some time in. It's called Copilot, that is a PDPM analyzer. And right now, two of our facilities are running tandem, rug-based versus PDPM, to just look and see what the methodology will do. So afterwards, we can show you. We can show you Kaiser's PDPM analyzer. Well, we're going to be cooler than you, though. Come on, just kidding.
So this the analyzer may be financial analyzer, but do you have any quality metrics that's going to be, and I'm talking maybe an example would be like patient falls during therapy.
Yeah, so the question is do we have any quality analyzers out there other than just the financial piece? And again, we can show you some of that information. You know, like we've got live data, we've also got a demo data, but we actually are taking the whole MDS. So the MDS is 46 pages. And today in CMS methodology world, every 7 days, we have to redo that MDS as a summary for our patient in-house, right? And within that MDS, it is falls, it's functional improvement, it's medication, it's all, anything that you could imagine that is measured on that patient every 7 days. In PDPM, that's not the way it's going to be. So for some of us, we're going, hey, this might be okay because we don't have to do so much on the MDS side. But the sad thing is that because we have to have them in by day 3, by day 5, we have to have a MDS in by day 5. That drives the entire episode for that patient until discharge. So if we don't get accurate discharge records from the hospital and we go off of what we think we know, that's a huge risk financially and quality-wise, because if we don't document it and CMS isn't letting us go back and redo them. So it'll be interesting. But yes, we can show you lots of quality data. Paul, oh, Ken, sorry, Ken.
Yeah, I want to return to the therapy question again. A couple of reasons for asking. What is going to be the incentive for SNFs under the program to, actively work to get the patients out of the SNF under BPCI? And I compare that to the experience of my own father being in a skilled nursing facility getting therapy, and I thought, he's getting therapy twice a day, but it looks to me like he could handle more therapy than they're giving him. And it seemed like the stay was extended because he didn't get as much therapy as I thought he could handle.
Go, yeah.
I'll just get next to you. So from the Medicare says that you can keep people in therapy as long as they're making functional progress on a daily basis. So generally, if you see them making their functional progress, then Medicare allows them to be there. The truth of the matter is the goal, I think, in most skilled nursing facilities, because the previous before October 1, our payment structure is based on rehab minutes. So the goal is to give them as much as you possibly can, because you're going to get paid based on how much rehab you're giving them. So just as you said, the goal would be for each facility to give as much as they possibly can based on that patient's progress. Having said that, going back to what Lisa said, if there's a difference between 680 minutes and that 710 and they missed it by 5 minutes, they fall back into that category. So like you said, maybe he could have had 5 days off of his length of stay, but because they didn't utilize their minutes in a good way, they lost that money and kept him for a longer amount of days. Going back to also what you said, the October 1st change with PDPM is now very nursing focused. And so that first 3 days, it determines their entire payment structure for their entire stay. And so our ability to show how acute these patients are is critical for each skilled nursing facility. Does it decrease the amount of rehab that they're getting? No, because they're coming to us so acute. We still have to give them the same amount. We still have to give them as much therapy as they can handle, but we're going to be looking not as the causation factor of how they're getting paid. It's going to be based on the nursing programs. So how much acuity is our nursing team putting into the first 72 hours of their visit? So if they're diabetic, heart failure, COPD, all of these different comorbidities, those patients were going to get paid more for the first time than somebody that has a hip or knee that can do 800 minutes of therapy. So I think that's, for us, that's exciting, because for our nurses, it's like a pat on the back, because they're finally getting some credit, I think, for all of the good services that they're going to do. Where I see, going back to when I'm presenting to hospital systems, I think hospitals are worried, what am I going to do with an easy hip or knee? Nobody's going to take these patients anymore. And certainly, I think that there will be some facilities that have cherry picked in the past that don't know how to handle the new payment structure and how am I going to make money on these easy patients. But I think that the first week of October, maybe that first month of October, is going to be a roller coaster for skilled nursing facilities until they figure out how they get reimbursed, and until they can figure out what that sweet spot is. So yeah, I could take 4 or 5 CHF COPDers with maybe diabetes and all these IVs to allow myself to take 10 more hips and knees. You see what I mean? They're just kind of monetarily.
Yeah.
All right.
Paul, did you have a question?
To what Mandeep and others were asking, there are elements of incentives with this, mainly because PDPM is a variable. The reimbursement is tapering as time goes on. The other element, as presenters have mentioned, especially, I know Lisa, you and I have talked about this before, one of the most interesting elements, I think Cassie just referred to non-therapy ancillary element of PDPM, this comorbidity factor and the baton pass. And the interesting thing to remember with Medicare regulations is Medicare is always pivoting. They will make big changes like PDPM, and then they go back and they look at the claims data, and they will realize that there were a lot of unintended consequences in what they set out to do. So I think the non-therapy ancillary component of PDPM is fascinating, because what it does is it sets up folks to really look at that. And Lisa, as you mentioned, having a coder for the first time, and that, what does that actual baton pass look like between the discharge planner and the admitting folks? Because being variable per diem, if you don't start as high as you can, then you're tapering from a lower point. So I think from an incentive perspective, the OIG has always said, well, RUG doesn't necessarily work because we look at the demographics and we're paying you the same, but shouldn't people be getting better? Well, this is supposed to be the common bridge between those two. Will it work? Time will tell. So.
Yeah, and I think Paul brings up a really good point. You know, what concerns us as post-acute care providers who really work hard to demonstrate quality. Our network, seriously, in the state of Oregon, you can go out to Nursing Home Compare. Where we have facilities, we are all 3s and 4, 5 stars in every facility, and in some areas of the state, you've got 1s and 2s and us. So we take quality super seriously. I mean, we measure it every single day in our KRAs and stuff. But I think what's going to be super interesting is, because CMS came into PDPM and said, this is going to be budget neutral to you guys. This is our goal, budget neutral. Well, it could be budget neutral if you didn't really focus on the drivers that are important, which the drivers that are important is that first 3 days. We're depending on our acute care settings to be able to give us better data on that discharge report and all those things. So what we're afraid of is that we are going to look like we're gaming the system, because we are going to focus more on the diagnosis code. I know from a health plan perspective, I got to focus on HCCs and specificity, right? Well, now my network is going to do that as well, which we've never done before. So CMS is now going to get some really good data from us, but it could look like they're getting really good data that change the reimbursement, and that's not it at all. But more importantly, your other post-acute care providers, you know, if they're not talking to you guys about this stuff, they should, because if they're not focusing on this, they could go away really quickly. PDPM is a huge change to us. It's the biggest change we've ever seen. And if they're not focusing, we're going to see some, we anticipate that we're going to see some sad closures or buyouts, more REITs coming in where they have overheads that are just exorbitant, that's going to really make the systems challenged in Oregon.
So you have 1 year to extract all the juice.
That's exactly.
Then they're going to change it again.
Yep,
Right.
that's exactly right. Okay, Cass.
Okay, nope. Give it back to. All right, so I'm balancing. This is the wrong data, not where pockets. So I want to just back up really quick and tell a quick story. So in 2010, as a company, we had 24 skilled nursing facilities in the Pacific Northwest and 2 in Las Vegas. And our 2 Las Vegas buildings were 50-bed plus vent units, some of our very, very most acute and most challenging patients. And in 2010, we had 2 facilities on an electronic health record, right? We were all paper charts at the time. And I think as a company, we generally think we're the best. I mean, just to be perfectly honest, like unless you tell us otherwise, I think we're pretty good. But we didn't have the data to back ourselves up. And I can talk a good game and I will tell everyone we're the best. But I think that, you know, people, unless you're showing them data, you can show them black and white information. It's just donuts that you're bringing to make friends. And I say that because when in 2010, when we started looking at our information, I was one of the people on the team that had to go out to our facilities and do the data collection in our paper charts. It took us, like, honest to goodness, 12 weeks to collect 1/4 of information. And at the end of it, there were several of us that wanted to take our own life. It was the most painful process of my entire life. And what we found out is we were just like the national average. The national average for skilled nursing facilities in 2010 was at 24, 26%, and we were right there. We were right there with every statistic that they had, whether it was every Monday we were readmitting most of our patients. Most of our patients were coming in with COPD, CHF. Those were the ones that we readmitted. And we were at 24 to 26%. And we had that aha moment where, we're not managing this. We don't even know what our numbers are. So there's no way we can move the needle. We thought we were better than everyone else. And so I fast forward to what we collect now and what we measure now. And so part of my job is I'm in charge of our hospital strategy. So I have the opportunity to not take donuts into hospitals anymore and try to make friends. I can actually take black and white data and show, all right, this is an apples to apples comparison. This is what we're looking at and how can we collaborate? And so for me, this has been a huge game changer to have this sort of data. So what are we looking at and what are we measuring? First, we're measuring that point of care and that when the patient arrives at that post-acute setting, whether that be the vitals, the meds, the activities of daily living, all of those things. So about 17, 22 days later, going back to our fee-for-service category, what we're getting paid for right now, for 17 to 22 days, we'll then do an MDS, and we'll collect all of the data about that patient, right? We're checking to make sure that our accuracy in MDS, we're painting that picture of what that patient looks like. And then we submit the claim, right? The claim gets submitted to CMS, managed care payers, data is received, reimbursement set, so on and so forth. And then the claims. So then the claims data comes up on the Medicare website. And what's the problem with that data? Sometimes it's almost 3 years old. Well, what can we do with 3 years old of data, right? It's retrospective. There's no change that you can make in the moment. I'll tell you, that's what most traditional vendors have. When I meet with hospital systems, they're pulling up Nursing Home Compare, Medicare.gov, and they're looking at our information from 24 to 36 months. And that's not good information. As well, Medicare.gov has what kind of information? Only Medicare. In the state of Oregon, we're 60, 70% managed care. So it's not really painting an accurate portrayal of what that information is. What we're able to look at is this optimal, this live data, right? And live data means I can see, because of the patient record and all of our electronic health records, I can see exactly what's happening with that patient. Lisa mentioned when the EDDI report. So when a patient leaves our skilled nursing facility and arrives at the emergency department, we get an alert via CMT that says, this is what the patient just admitted for, this is where they're at, and it gives us an opportunity to divert those patients and get them out of the emergency department and not have that readmission penalty. Going back, it behooves us both. We're gonna get a Medicare penalty for it and the hospital will. So if we can be innovative with that and be able to, in the moment, change something that maybe has 36 months of information so late, it doesn't allow us to make that change in a good way. So like I said, part of what's interesting from my job, and at every hospital that I present at, we'll ask the skilled nursing facilities to send in your readmission information. Let's be transparent, let's look at things, let's try to help the hospitals see what opportunities we have to collaborate. And I'll tell you, every skilled nursing facility has a different electronic health record, right? And so it's hard to normalize the data. It's hard to collect it, it's hard to normalize it, and every skilled nursing facility started measuring their data a different way. And so there would be countless meetings that we would be, sitting with the hospitalist team looking at all Monday readmissions. One skilled nursing facility would say, I have a 48% readmission rate. Another skilled nursing facility would say, I have a 7% readmission rate. They're not measuring their data the right way. And so Copilot, what our live data analytics solution is it's taking all of the, whatever EHR that you have, we currently have 37 that we've matched with, and we're asking them to submit their data every hour on the hour to Copilot. And Copilot is our live data analytics solution that allows us to look at our provider results. So again, our focus is digital innovation and analytics, but what that means is that we're able to look at these public data sources. And so whether that's the inpatient claims, the SNF claims, cost reports, I said that Nursing Home Compare, the SNF survey trends, hospital readmissions, the penalties database, all of these things are into one system, and we call it Copilot. Again, it's allowed us for our Medicare Advantage, sorry, I've got my back to you. So with our Medicare Advantage plan, with that data integration, it's just been key. we're able to do real-time data reporting. And so when I'm meeting with our providers, whether it be our hospital systems or BPCI advanced partners, we're able to look and see, what did we just do in this last quarter? Not 36 months from now, but what did we do right now? And what opportunities do we have to improve what our results are showing? So we had talked earlier, someone had asked about how do you see, what kind of reports do you have that look at quality? And so this is, again, looking at, what are we looking at in Copilot? We're looking at the live claims data. I mentioned that we had 37 EHRs and databases. What are we looking at with those? We're looking at the skilled nursing facilities. We're looking at the hospitals and then the physicians. We're looking at the pay for performance measures. We have live alerting on all long-term and short-term measures. We're looking at readmissions, emergency visits, and functional improvement scores. Again, core Q, we're also looking at the HEDIS measures. How does a SNP impact the financial well-being of the health plan? So up here, let's see if I can use this. Yeah, right up here, this is a group of 4 different, I'm gonna try to move. So these are a sample of our reports. At the top, we have the readmission rate by facility, followed by ED visit rate by rate trend, NDS section GG improvements by top admitted diagnoses groups, and then the core Q trends. When I'm meeting with hospitals, we're going over all of these reports to see what are the trends and what are the analytics that we can use to give a better optimal experience for our patient population. Sorry. Yes, please. All right, so tag team here. So this is the DRG cost, I'm sorry, I'm gonna point a couple. This is the DRG cost analysis. And so as I was mentioning, being able to go to a hospital system and say, all right, let's look at our hips and knees, for example. And so you can see, I just pulled I used every state in the nation. I pulled a couple of quarters. And I'm looking at DRG 470 major hips and knees. What I like about this, when I'm meeting with hospital systems, if I just wanted to look at one quarter, what I could look at is how many episodes did they have of the hip and knee? What was their inpatient average cost? What was their inpatient length of stay? What's the SNF average cost with this patient population? What's the SNF average length of stay? Home health, and then home health average length of stay. And so we're looking at BPCI providers and good partners. Are you being a good partner and steward with the money? It's interesting for me, and I'll use Eugene as an example. Eugene has 2 hospitals, Riverbend and Mackenzie-Willamette. I was meeting with the hospital system and I'd pulled up all of the DRGs that one of their orthopedic providers in town was using. And when we were looking at it, it was interesting to see, one, you could see who was getting the bulk of the hips and knees in town, but you could see the change in cost. One hospital was paying $40,000 more in their inpatient costs than the other hospital, which is interesting to kind of start wrapping your head around. So it's kind of a can of worms that you can open up to have these dialogues, but it's been awesome to be able to look to see, all right, as a skilled nursing provider, if our goal length of stay for a hip and knee is 7 days and my average is 11, are my patients more acute or what's happening? And maybe if another provider is doing it in 10 and another provider is doing it in 5, then that's your narrowed network, right? You can start to see who's getting better results, who's managing the costs more, who's managing the patients better, and who's getting the outcomes. So again, you can run this for every hospital system in the nation. You can run it by any DRG that you want to look at, and it allows you to drill down. Any questions? Sorry, this is so small. All right. Fantastic. All right. Oh no. Oh, there, okay. All right, so going back to data can and should drive decisions. So I think that we're in this unique opportunity where we're looking at data and how important it is. We have 2 different kinds of data right now. We have retrospective data and we have transitional data, right? Retrospective is that reactive data that you're looking at that gives you kind of a snapshot of the past performance. And then real transactional data is more action-oriented. real-time, proactive. And that's where we need to get as an industry. Rather than looking at the 34, 36-month-old data, we need to be able to make actionable insights and be able to move quickly with our partners at the same goal. So the new realities of BPCI. Medicare Advantage reimbursements for fee-for-service is either flat or it's decreasing. We anticipate with our post-acute care that we're planning on experiencing less than the CMS reimbursement. Post-acute providers, along with, the post-acute care and the PDM change, we're anticipating that we'll probably see reimbursement decreases of 5 to 10%. So while Medicare says that it's budget neutral, I think we're all kind of preparing for a different reimbursement. There's a lot of pressure on hospitals, skilled nursing facilities, LTACs, inpatient rehab facilities, and home health to accept reimbursement at less than the Medicare rate. Payers are incentivized for utilization management days. Unless hospitals, skilled nursing facilities, inpatient rehabs, unless you can really show evidence of the clinical care management, and through that, your good outcomes, you're going to be penalized based on the time that you're taking with those patients. Hospitals and post-acute care are taking steps to prepare for that risk or that or how to manage that risk of BPCI. And so an example of that would be 2020, January, I think, 2020, you're able to re-up on your BPCI. And I think that it's, for a lot of hospitals, they're going to look at what episodes are we participating in right now? Are they the right episodes for participation in the future? You had mentioned that OHSU is participating in 12 or 11, and you just lost one. And I think that that's what a lot of hospitals are going to be doing in 2020 is looking to see, did I meet my goals in this last BPCI Advanced, and what do I need to do to functionally improve those goals for the next model? Any questions? So like I said, that BPCI shift and what that looks like, we're moving from a transactional relationship to a partnership. And that includes, in the transactional relationship, right, we didn't have any economic incentives to align ourselves with a fee-for-service, right? We had no incentive to collaborate or to have meaningful goals or common goals, if you will. Whether that was pay for performance, value-based purchasing, or so on. There was no evaluation of operational efficacy of either party, right? We weren't measuring what our partners were able to do. On the partnership side, now we're looking for opportunities for that economic incentive alignment. We're looking at quality, utilization, post-acute episode, the total cost of care reduction. We're looking at joint operating reviews to review results and collaborate on what best practices are. And again, we're trying to drive efficiency in our partner workflows. And so I think it's a new day for post-acute care providers and acute care hospitals to look at, all right, how can we meaningfully benefit one another's practice at this point? So I like high-performing BPCI partnership. It requires a culture change. I remember going into hospitals, when I first started, we weren't allowed into hospitals, like skilled nursing facility providers. We weren't allowed to meet with care managers or even go see our patients. That was just two different silos, and our silos didn't touch. And I think that in the last few years, part of what's made my job really fun is that we're trying to figure out, all right, you have something to offer, I have something to offer. What can we do to help each other? And so someone was saying earlier, it's much easier to take a process that someone's already deemed best practice and adopt it as your own. And I think that that's what we're all kind of trying to do. I sit on a lot of skilled nursing facility transitional care committees. And so that's where there's Salem Hospital as an example. There's 16 skilled nursing facilities that meet with Salem Hospital every month. And we're looking at what process improvements do we need to use? Do we need a lean process to figure out, something that we're all struggling with? And we've seen our readmission rates as a collective group just drop tremendously. We're speaking at Magnet this year because of our success in meeting and having these important dialogue. But it's that culture change, right? It's that culture change where Salem Hospital all of a sudden had to say, all right, you have something that we need to welcome you with open arms. And for skilled nursing facilities, part of our goal with that committee is what can we do to make this hospital run faster and better and all of those things. Salem Hospital, ironically, is this largest emergency department, busiest emergency department from San Francisco all the way up the West Coast. Salem. So there's a lot of opportunity to really affect change there because there's just so busy. What does that cultural change look like though? You have to have actionable insights to identify what your problems are. What are you looking to solve? And so as a group, we're looking to what do we all need help with as a collective group? And then what information do we all have to be able to bring to the table to solve this problem? And at the end of the day, it's all data, right? Data is the key. And so once you have that system platform or that data, you're able to drive that information and then gain actionable insights, which allows you to make those changes rather than 36 months later, 6 weeks. And so that's been huge for our organization. So goals, BPCI goals. At the end of the day, we're trying to get better production through better performance. So we're looking for better population health with lower per capita cost and a better patient care experience. And really that's the AAA. So we're talking about BPCI. One of the things I wanted to talk about is who can initiate episodes. So in model 1, the episode of care was defined as the inpatient stay in the acute care hospital, right? In episode 2 and 3, it involved a retrospective bundled payment arrangement where the actual expenditures are reconciled against a target price for the episode of care. So who could initiate episodes? Hospitals, physicians, and post-acute care providers. And so regardless of which model it was, those were the main players. In episodes 2 and 3, it was only the inpatient stay that could initiate a BPCI episode. And so for those that aren't as familiar, models 1 and 2 and 3, there were 48 episodes. You could choose, there was 30, 60, and 90-day episode duration. And again, the goal is for whomever was the episode initiator is to pick the DRGs that they thought that they could perform better in than the year before. And so it's been really interesting to kind of see how the country has wrapped their head around bundled payment. We as an organization don't see bundled payments going away. We anticipate they're going to get bigger and more intense and include more things. And so just from a breakdown, as of July 1st, with the BPCI initiative, there was 1,025 participants in the United States. Of those, the breakdown of participants were 255 acute hospitals, 485 skilled nursing facilities, 192 physician groups, and 43 home health agencies. I say that because I think for so long, we didn't really see each other as we're part of this big collective. And I think that skilled nursing facilities really downplayed their role in the success of BPCI. And I think that with those new counts that came out, skilled nursing facilities make up over half of the awardee for the BPCI collective. And so I think that for us to be able to make more of a conscious contribution to this is a good thing. Again, in this BPCI, all claims paid as normal retrospective reconciliation. So what claims are included in an episode? Under the Part A services, obviously, under the Part A services, you had the hospital services, the skilled nursing facility, the home health agency, you had the long-term care, and you also had the inpatient rehab. Under Part B services, those are the physician services, the therapy outpatient services, and then your DME, durable medical. And then under the rehospitalization and ED visits, obviously, you don't want those to occur. And so to be able to measure that and see what is included in that episode was critical for us. And so this is where I get to tell another great story. So been in this business for a really long time, and you have your fierce competitors, right? And I say this because one of our fierce competitors was Avamere. And Avamere is a Oregon, Washington-based skilled nursing facility, but they're also our newest partners in crime with this post-acute care network. And so it's fun to be able to tell their story in a way that isn't mean. I'm kidding. in a way where we're actually partners and we're able to talk about, as a post-acute care continuum, what they've learned from being a convener in Model 2, what we could have learned being a convener in Model 2, and so on and so forth. And so Donna Mueller is the vice president of Avamere Family Services, and she was gracious enough to give us the story, and she was going to be here today but had a commitment she couldn't get out of. But I wanted to, they were the only skilled nursing facility that took on the convenership in Model 2 in the state of Oregon. So I kind of wanted to walk through what they learned and what effect this had in their BPCI. Excuse me. All right, so again, largest PAC provider taking full risk of BPCI. Day 1, patient admitted to the hospital for a specific episode. Day 4 is typically when those patients were discharged to a post-acute care provider. Patient follow-up with their appointment or physician generally was done on day 11 with Avamere. On day 25, the patient was discharged from a post-acute care setting to home and received home health. Day 32 is generally when the patient readmitted to the hospital. And then day 90 is when that bundled payment ended. So this is kind of the life cycle of the Avamere patient and what happened during their Model 2. It's interesting because the things that Donna had said would have made it better, or that made a significant impact on them, was the care redesign and adherence to improving the overall care was critical. Utilizing the post-acute care network in Oregon, it was already really, really low, the post-acute care providers. And so for them to be able to control the network flow made a huge difference. And what they meant by that is if all of the Avamere facilities are sticking to the exact same protocols in all of their buildings, they're able to much more effectively manage things than a one-off independent facility would have. And then again, the key lever there was avoiding the hospital readmission. And so what they also learned was that the awardee receives monthly data feeds on claims, but the full claim data is not considered complete with runout until 90 days after the claim period ends. So the first year of data review can feel like watching paint dry. I didn't realize that it was that long of a life cycle for that. The reconciliation occurs roughly 6 months after the end of the reconciliation, after. And so the end of reconciliation period is a very, very long wait. There may be claims adjustments at reconciliation that were not present in the claims feed. These may be due to precedence, or another provider has precedence on the claim, or it may be due to a behavioral medical stay, which is not evident in the claim file. So again, they're having to dig to try to figure out if they're getting the reconciliation that they were supposed to. Post-acute care providers are the best qualified to determine the post-acute care gaps in care and close those gaps in care, were one of the things that Donna said. In Oregon, few patients arrived at SNFs who aren't medically complex and required a skilled stay. So going back to what you were saying, almost all of the patients at the skilled nursing facility were absolutely appropriate to be there. I think back in the 90s, we had what we called lovingly referred to as walkie-talkies. And they were like patients like you and I that just like had a little hip issue and were walking around the facility and just like needed basic care. We just don't see those patients anymore. The other thing that that Donna said was that post-acute care providers can and do control adverse events if they are quality focused. And so by aligning all of their teams, assuring a best practice, whether it be specific to a diagnosis or whatever, made a huge difference in their BPCI. Again, the goal there was narrow the networks, adhere to the goals that you're setting, lower the cost, and increase the patient engagement. And so now we're in BPCI Advanced Model 2. And as I mentioned earlier, the second cohort starts January 1st, 2020. And so for the hospitals that are participating right now with your episodes, I'm guessing that you're starting to look and see, am I meeting the mark with those episodes? Do I need to add or gain one to meet my goals in that, in that period timeline? So the whole picture. going back to good and bad utilization, I think that good utilization it's easy to explain. You want to have your pharmacy medication adherence. You want to have medication reconciliation. You want to have additional office visits. You want to have home health involved, labs involved. You want to be able to really talk about what you can do on the forefront so you don't end up in that bad utilization, which is characterized as the emergency department or an inpatient acute setting, whether that's in the ICU, the med surge. We're trying to decrease the amount of inpatient subacute days. We want to decrease the dialysis, the diagnostic radiology, the hospice, outpatient surgery, and other surgery electives if we can continue to provide the mental health, preventative care, and so on and so forth that we know that our populations really, really need. And so what are the most effective speed to market care management programs for high opportunity population segments? And what can we do as a care team today to engage people to enroll and participate in programs that are effective? And I think that's part of what my job is to be able to show how a network of providers can really bring down the cost. I would just segue into going back to that Eugene example. We have 2 hospitals, 1 skilled nursing facility that we manage in town. And it was shocking once we put that nurse practitioner into place and increased those well visits and eyes on those patients, we went from a 14.7% readmission rate down to 5.8. And it was just in like 6 months, and had everything to do with just having more well visits and more eyes on the patient. And we call it the God forbid or the oh crap situation. I know it's political. Oh God, I fear that I'll ever have to be in a nursing facility. Please don't ever let me be in a nursing facility, or oh crap, I'm at a hospital, I'm going. You know, so nothing prepares you for a post-acute event. It's how do you manage it, and how does the teams around you manage it so that you can mitigate big issues. So that's kind of my take on utilization and how to go from a bad utilization provider to a good utilization provider. And a lot of it just has to do with being able to have a lot of that preventative stuff on board. So at the end of each of our presentations, we like to have at least 4 things that you're going to walk away with, right? So our 4 to know: changes in healthcare delivery and bending of the cost curve will make us more accountable. Adoption and integration of analytics is a big driver of change. As Lisa mentioned before, we have a lot of different platforms that we think have been incredibly helpful that we're happy to share with any of our members and providers. We just think that transparency for our network is a good thing. New financial models will align incentives and modify behaviors. And finally, aligning behaviors with provider partners. Those 4 things we really see as critical for, 1, moving and increasing your BPCI participation, finding better network providers amongst any of your communities, and understanding what that provider network can do to help the success of your hospital or company, and so on. And so we're thankful to be here today. If anyone has any questions, Lisa and I are open to answering. I know, look alive. All right, awesome. I think we bought you 15 more minutes if no one has any questions. Yes, please, Mandeep.
So one of the concerns is like high cost drugs. So the PDPM rate includes drugs, right? The NTA portion.
Yep.
Ancillary. So is that enough then overall on an average basis to cover high costs?
Oh, yes, I can repeat the question, I think. I'm just kidding. So is the amount that you're receiving under PDPM enough to cover the cost of the drugs, is what you're asking? Yeah, including high cost drugs. Do you want to answer that? Or do you want me to?
Yeah, I don't know if you guys can hear me. I would say yes. We think the key to high cost drugs is, 1, making sure you have a good pharmacy partner, which, you know, we believe that having long-term care pharmacies is the way to go. We get, you know, bulk pricing just like many other ones, but more importantly, it covers the cost if you get Medicare reimbursement. But if you're under Medicare reimbursement, you can't cover the costs, and that's where things get a little wonky. And it's that way today, and it'll be that way in PDPM. But I think PDPM, because of the nursing and the NTA being a little more focused in there, I think we're going to be ahead of the game. And really where we think it's really going to have the win is on the medication reconciliation side, because it's not so much the high cost drugs are something to think about, but more importantly, we see when we change the medications, when they get to our facilities, we get them to a generic, or, you know, the orders come and it says, you know, I'm not clinical, so I'm going to make this up. But the orders say, you know, 5 a day on 10 milligrams, when you could actually give them 2 on, you know, 5 milligrams or whatever, you know, whatever the math is. That's where we see our pharmacists actually doing that reconciliation on the discharge planning with the hospitals.
Another question. So with the new diagnosis codes that you're going to be harvesting, do you anticipate a big uptick? Because that's my concern in the Virginia, because of the 3-day and then maybe even cherry picking the patients, more acute patients to get them higher reimbursement. You know what I'm saying?
So I'm going to try to restate that. So the question is because of the more specificity in the diagnosis coding, there's a potential for post-acute care providers to choose higher acuity patients and not focus on the hips and knees.
That's 2 issues. Like, one, would our reimbursement go up in this year? Because now your mix is going to be more on the high acute side, and you're also trying to get those diagnosis data in the G. Remember how you were saying CMS will think that you're gaining it? So in that first year of transition, would the reimbursement overall go up because now there's so much attention being paid to diagnosis codes than before, and then maybe also coupled with cherry picking those patients more because of you get paid more in the first 3 days, so the mix is more towards the high acute patient than the hip and knee replacements.
Yeah, so I mean, essentially what you're asking me, Mandeep, is are we going to do you think that the post-acute care providers will cherry pick, and will the reimbursement and acuity be disproportionate? And what I can say is in our network and in our providers, we're not anticipating that. What we're anticipating is 5 plus 5 below kind of reimbursement change. Because here's the deal. We hire therapists, right? If all I focused on was that high acuity, what do I do with these therapists that still cost me money, right? I still got the labor, so I still have to keep them. So really what we're trying to do kind of across our network is keep it even and not to disrupt it, because we don't know. We think based on the PDPM analyzer that we've been using and we've been running in parallel for the last 30 days or so, that we're going to come pretty close to even. But you know, what I did on my health plan is I just went to a flat per diem, 1 per diem for them, because on those really, really high acuity, I think that there could be some change. But post-acute care facilities are not going to be able to manage just that high acuity because they don't have the staff that way, right? We've got staff to manage the care that we're getting today. And we're not going to change that staffing model on 10/1 because of all of these changes. So I don't know what other post-acute care providers are doing. I know we are trying to just stay budget neutral and manage through what we have. We're not planning to change who, you know, which patients we take or don't take. Because one, how would that look? Like, you know, we talk about align your behaviors with your provider partners. How would that work for SANIM or OHSU or Kaiser or Legacy if my liaisons were talking to your case managers and telling you we're only going to take your sepsis patients or your open wounds?
I do understand the second point, but the first point still remains, right? Like because now you have all this diagnosis data that's heavy on the first 3 days of reimbursement. The reimbursement levels may be higher in the first year of PDP and then the drug in the previous year.
I think the net is going to even out. You're absolutely right. The first 3 days are going to be heavy weighted. But how many post-acute care stays end in 3 days? Unless they expire. They don't. I mean, the average length of stay, and Paul can jump in, the average length of stay is 14 days. In our model is 14 days. So I don't think so. And the deal for CMS, jump in here,
It's supposed to be budget neutral.
was to be able to reimburse the post-acute care setting for that heavy on the admission, not to disproportionately not reimburse the rest of the stay. So you want to jump in there, Paul?
I was just gonna say, Andy, you're pushing really hard on that first point, but that point assumes that 10-1, that all of these skilled providers have this locked in,
Right.
perfect line of sight to their detail. This is not a reimbursement change as much as it is a clinical and operations change.
Yeah.
This is huge. Just trying to get through the first year of PDPM, providers are just trying to recalibrate and get line of sight. I think what you're gonna find, and Lisa, your point, you and Cassie have really kind of solidified this in my mind, is right now, think of it as kind of a slightly blurry picture, and all of a sudden PDPM really brings that population into focus. But it's gonna take time because all of those factors will have to come into play with surgical cases and acuity and medication reconciliation and all those pieces. So not that it's not a concern, I just don't think people are so on top of it that they're gonna be locked and loaded.
Yeah, I would agree. I don't know, as we've done, because we've done PDPM training, consanus, across the United States. We did Portland, some of your staff was there. We did Washington, Peoria. And I can tell you, there's a really wide variety in the knowledge. So.
And that's the same with managed care.
Yeah.
Providers.
Yeah, managed care payers. I've asked to do like testing with them. Are you going to be ready? I've had not one managed care payer come to me and tell me that they're going to be able to cut a check in the PDPM methodology on 10-1. That's frightening, right? Like it takes me back to like starting over Y2K and 5010 and all those things. We just don't know. So we have a bit of a risk. No.
Exhausted. BPCI Advantage, is any commercial care doing that? Only Medicare?
Yeah, no, we don't have any contracts today in any of our settings where any payer is ready for BPCI. It's kind of unique. I mean, I would have thought, especially given now, 2015 to 2018, we saw that we're going into that second round. I would have thought they would have been ahead. But what I can tell you is payers don't necessarily think about post-acute care. We're not an OHSU. I don't know what's OHSU's annual income. Like my largest Medicare Advantage payer for marquee companies alone is about an annual spend of $7 million. So we don't mean enough to them yet to really move. And until we all get together on that post-acute care continuum, because the hospitals are getting dinged for readmits and EDs, we're getting dinged for readmits and EDs, we're getting it, all these quality things, and the Medicare Advantage payers just don't have to pay attention to it. Sorry. but I mean, we're just not big enough. We don't mean enough to them yet. And I get it. They're putting out fires in lots of different ways. They got CCO 2.0 coming. God help them, So I think they just haven't got there yet. We're pushing. I talk to them a lot.
All right. Well, thank you for your time today. Enjoy your afternoon.
Thanks, everybody.